Research, Shaping the Future of Your Care, and is the last session in our patient-centered outcomes research track. Many of you have participated in one or more of our featured PCOR Lunch with the Expert tables or the Friday breakout session on peer mentorship. If you have not, please take a moment to complete the brief survey at your place setting and return it to the AAKP Registration Center. I am now pleased to introduce our session speakers who will present in the order introduced. Ms. Sarah Van Gertrude, thank you, apologies, is the Executive Director of Partnership to Improve Patient Care, a diverse group of healthcare organizations representing patients, healthcare providers, researchers, and innovators, and other groups to promote comparative effectiveness research that supports patient access, informed healthcare decision-making, and continued medical progress. In this role, she is responsible for assuring that the voice of PIPC's members is heard by those implementing comparative clinical effectiveness programs, including PCORI. Dr. Lee is a professor of medicine at Emory University and chief director of Emory Dialysis. Her research and clinical interests are in hypertension, chronic kidney disease, and dialysis. Dr. Lee has served as the Emory principal investigator for the NIH study titled African American Study of Hypertension and Kidney Disease, and the national medical spokesperson for the National Kidney Disease Education Program, sponsored by NIH. She is also a member of the AAKP Board of Directors and principal investigator of both of AAKP's PCORI Engagement Awards, including our recently underway PCORI Dissemination Project titled Enhanced Patient Engagement to Improve Patient-Centered Outcomes Among CKD. I would now like to invite Sarah up to get us started.
Just go forward. There we go. Thank you. Sarah Van Gertrude, I know it's 14 letters, which, I always laughed that when my youngest was, or my oldest actually was in the 4th grade, our last name was the bonus question on his spelling test. So anyway, this is what happens when you marry a Belgian. But thank you for having me. I'm really excited to be here. As some of you may know, and I'll provide just a little bit of background about the Partnership to Improve Patient Care, and really the face of our organization is Tony Coelho. If you remember Tony was a congressman from California who wrote the Americans with Disabilities Act. He reminds me every day what our mission is, that our mission is to make sure that patients and people with disabilities are at the table, and not just at the table, but have a voice and have their feedback incorporated into policies, research, et cetera. One thing that we often kind of get annoyed at is often you have patients at the table, but that doesn't necessarily mean that their input's being taken. It sort of feels token. And it's really been Tony's mission to get beyond that sort of tokenism in healthcare with patient and disability engagement, starting with the Americans with Disabilities Act, and now with PIPC, we strongly supported the creation of the Patient-Centered Outcomes Research Institute for that reason. You may remember that back in 2008, 2009, there was this hot debate going on in Congress about comparative effectiveness research. There was an acknowledgement that we needed more of it, but at the same time there was some controversy because on the far right you had members who A, didn't want to pay for it, and B, would argue that if we do this kind of research looking at the comparison of treatments, we're going to translate that into coverage decisions and therefore start creating more barriers to care, which in this age of personalized and precision medicine was a potential negative consequence. Senator Pat Roberts is here, and as he said, it won't be long before Medicare starts rationing care, was his perspective. On the far left, you had a different view. On the far left, we actually had members who supported the creation of a Comparative Effectiveness Research Institute, but wanted it to focus on cost effectiveness and wanted it to be translated into Medicare coverage decisions. They wanted to use this information to say, A works better than B on the average patient, and therefore we are only going to cover A, which, as we all know, doesn't work in real life because not every patient reacts the same to different treatments. And so what ended up happening is that PCORI was created from a centrist point of view. Senator Max Baucus, who was chair of the Senate Finance Committee at the time, and Senator Kent Conrad, who was chair of the Budget Committee at the time, or they went back and forth between ranking and chairman. But they were pushing this Comparative Effectiveness Research Act in 2008, which eventually evolved into the Patient-Centered Outcomes Research Act of 2009. And then PCORI was eventually passed as part of the Affordable Care Act as a compromise between the right and left. So sometimes you'll hear about PCORI, because it was part of the Affordable Care Act, people will attribute it to being partisan, but in reality it was not partisan. It was one of the bipartisan pieces of the Affordable Care Act, which, while not having a lot of Republican support, not having any Republican support when passed, it did have Republican support when it was being drafted. So PCORI supports improved health decisions in many ways, and PCORI was intentionally created to be patient-centered by, and if you look at the statute, there's a lot of references to looking at subpopulations, disparity populations. We wanted PCORI to be a trusted and credible source of information, which only happens when you have engaged partners. We wanted PCORI to do effective dissemination, and I'm so pleased to hear about the project that Dr. Lee's engaged in, because that dissemination piece of the puzzle is really, I think, the piece that we're going to be focused on for the next 10 years. PCORI supports improved health decisions by providing more evidence that we can then include in decision aids, things like shared decision-making tools and value assessments. And because PCORI's information is developed in a manner that looks at various outcomes and how those outcomes impact different people with different characteristics, it's not intended to drive a one-size-fits-all healthcare system. It's intended to help people make individualized healthcare decisions. So there were some patient protections in the statute intended to drive that outcome. Comparative effectiveness research in the statute is defined as comparative clinical effectiveness research, not cost effectiveness research. PCORI's research is explicitly prohibited from being the sole source of a Medicare coverage decision. There's something called the Quality Adjusted Life Year. It is a metric that is often used when doing cost-effectiveness research, where the value of a life of a person with a disability or a person with a serious chronic disease is given a lower value, and then they look at the cost per benefit and what the incremental increase in health is over time. Ultimately, the QALY has a discriminatory impact in terms of the outcome of that study, and so PCORI is not allowed to use a QALY, nor is Medicare by statute allowed to use the QALY in its coverage decisions. It also made PCORI an independent institute, and we were just talking about this. Dr. Lee was asking about that point, and so PCORI was created by Congress, so it's a little confusing. How can something created by Congress be independent? It was created by Congress, but at the same time, it is independent. It is funded through a tax on health plans that goes into a trust fund, and then the trust fund spits out the money to PCORI. But PCORI itself is led by a board of governors. It is independent from Congress. Congress doesn't hold the purse strings and tell it what to do. Also in the PCORI statute, they gave 2 seats to patients and 1 to consumers on the board of governors, thereby providing patients a seat at the table in terms of the decisions that are being made by the board. And the statute also explicitly outlines patient needs, outcomes, and preferences, and the subpopulations that are to be studied. Support for consumer and patient representatives. Some of you may have engaged in the patient engagement advisory panel at PCORI that resulted because the statute gives PCORI authority to create those kinds of advisory panels and to support them. So PCORI, and you'll probably hear a lot more about this from Dr. Lee, so I will let her focus on the studies that PCORI is doing on kidney care. But just as an overview, PCORI has funded 19 comparative clinical effectiveness research studies on kidney disease. They've also funded other investigations in which kidney disease was among several other conditions studied. And the work that PCORI funds then helps patients to understand questions such as the pros and cons of various treatment options, how unrelated drugs function in people with kidney disease, and how care delivery models affect outcomes. And in terms of populations of interest, you can see here a little bit of an outline of that. One PCORI-funded kidney study found that patients undergoing hemodialysis fared better if they were using antidepressant medication than if they underwent cognitive behavioral therapy. And generally speaking, they target studies that help patients and caregivers to make informed decisions. So here's the part that we need help on, PCORI reauthorization. So right now, the status of PCORI reauthorization is that there is a health extenders package that's being considered in Congress. As some of you may know, if you're familiar with the legislative process, there tend to be lots of different programs that then, once they expire, have to be extended. So PCORI is being considered as part of a larger package of programs such as the Children's Health Insurance Program and Disproportionate Share Hospital Program and others. The challenge is that this extenders package has become somewhat controversial in Congress, and so it's unclear whether it will actually be done by September 30th, which is the date on which PCORI's authorization expires. That being said, if PCORI's authorization were to expire at the end of September, they do still have money that they have designated for their existing programs. So the existing research projects would continue, and the hope is that by the end of the year, PCORI would then be reauthorized as part of that larger extenders package. So while we want PCORI to get extended before it expires at the end of September, it's not the end of the world if it doesn't. They still have till the end of the year to get all of that done. It is possible that some of those programs in the extenders package could be some of those programs could just go through what's called a continuing resolution and be extended for a short period of time, but we would still be fighting for PCORI to get a long-term reauthorization at the end of that process. So right now what we're waiting on is a discussion draft in the Senate. There are 4 members of the Senate who have taken the lead on PCORI reauthorization. That's Senator Cassidy from Louisiana, Senator Warner from Virginia, Van Hollen from Maryland, and Comparative from West Virginia. Those 4 members have put together a discussion draft of legislation that we are waiting on. We hope to have a draft to view and to provide feedback on in the very, very near future. It is my understanding that they've all signed off on it, but we haven't seen it yet. On the House side, Congresswoman DeGette has been really leading the charge. The Energy and Commerce Committee bill that they marked up out of committee has a 3-year authorization of PCORI, though, which is something that we do have concerns about. We had been pushing for a 10-year reauthorization, so 3 years is something we're hoping to get them over the finish line. It's something better than that. The Ways and Means Committee did extend PCORI in their marked up bill by 7 years, which I think at the end of the day is probably pretty good. We have been on record supporting 10 years, but I do think that at the end of the day, if 7 years were the ultimate number, folks would probably deem that to be a successful reauthorization. So then the question becomes, what can you do? PCORI's number 1 constituent is patients. We have been really pushing for patients, particularly patients who've been engaged in PCORI-related projects, to go to the Hill, to talk to their members of Congress back in the district, and just to make sure that they know the positive impact that PCORI is having on real people in real life in their states. If you go to and I'll get to this, but the PCORI website, but there are places you can go to get resources to better understand what projects are happening in your own state. Patients are also constituents for every member of Congress, and so we would encourage you to be connecting the dots for members. Friends of PCORI Reauthorization is a coalition that has emerged just in the last year. So while the Partnership to Improve Patient Care was sort of the coalition that drove PCORI's creation, we recognize that there's an even larger group that wanted to be part of PCORI Reauthorization. And so Tony Coelho partnered with Dr. Phil Gingrey, who is a former Republican member of Congress. He actually started the DOC caucus over in the House. And he expressed interest about a year and a half ago in getting involved in this issue because he has a very unique story, actually. Dr. Gingrey opposed PCORI when it was first created. He was part of that far right that said that he thought that it would translate into coverage decisions and create barriers to access to care. And since PCORI has been created and he has seen the impact that it has had and how much it helps doctors help patients, he is now a big champion for PCORI. So it's really interesting. If any of you went to the PCORI annual meeting last year, you may have seen him on the stage with Tony talking about that experience. But we're really excited about that because it's always helpful to have a bipartisan group supporting any sort of reauthorization effort on the Hill. So the Friends of PCORI Reauthorization, if you haven't signed up already, please do. We would love for you to go to our website at reauthorizepcori.org to get our updates. We are a large and growing group of patient, family, caregiver, provider, employer, payer, industry, and research stakeholders looking to support PCORI's Reauth. Right now we have around 177 member organizations, although that's growing. We had a letter in the past signed by 170 organizations to House and Senate leaders supporting PCORI reauthorization. We are expecting to have another letter very soon to the House. We want to explicitly support the Ways and Means bill that had PCORI reauthorization at 7 years as opposed to 3. So look for that. And then once we see the Senate draft bill, I anticipate that we'll have a letter that will be circulating to support that as well. And before I wrap up, just a couple of things to them. I would say, there are two main things to flag in terms of the reauthorization package and where we see it going. I think it's just very important to be supportive of a long-term reauthorization when you're talking to members on the Hill. The other thing that I am hearing is that there is some consideration to changes on the Board of Governors. There could be some more seats provided to the payer-insurer groups. So that's something else that we're just looking out for in the Senate bill. I don't know how many. And we don't think at this point that they're going to be doing anything on cost effectiveness, which would be a great win if that's the case, but we haven't seen the draft. But these are the kinds of things that if you sign up for our updates, we'll be providing feedback on so that everybody understands what is or is not in the Senate discussion draft. So that's all I've got, and I'm happy to answer questions at the end if anybody has anything they wanna ask further.
Good morning, everyone. It indeed is an honor to be here and to really meet all of you. I've had the opportunity to talk a lot with a lot of patients that I haven't met before, and it's just been a very rewarding experience. And what I want to do this morning is sort of focus on why you all need to be involved in research. You've heard the background about PCORI, and I want to specifically talk about opportunities for patients to get more engaged in the whole process. Now, why should patients be involved? Well, this slide just really tells you this. You're the patient. You're the patient who has to go through all these different stages. This pointer doesn't work, right? Okay, it's okay. That goes through all the stages of chronic kidney disease. And I'm very happy that there are several patients here that have chronic kidney disease. I met some of you, and I think that's so important for you to be here so that you can benefit from knowledge to help keep you from going to dialysis or transplant, hopefully. So basically, the life of a kidney patient involves several stages, that from CKD to pre-ESRD, and then to where they have to go on dialysis or get a transplant. And within that scheme, you can go back and forth, and many of you in here have had dialysis, you've had hemodialysis, you've had peritoneal dialysis, you may have had 1 or 2 transplants. So it's really a continuum, and that's why it's important for you and other patients to be involved in the whole process. It indeed is your life. And so we talk about in dealing with patients with kidney disease and developing a life plan. And this is something that I think is really helpful from day one when you first meet your kidney doctor, to really go over specifics about what to expect. Because in talking with a lot of you and patients that I interact with, they didn't really know all of the consequences of having kidney disease. They didn't know that once they got on dialysis, that they might have issues with their access, that they might have to go to another type of dialysis, etc. And they didn't really know what things they needed to do to improve their health. So really, I think it's ideal for patients to have a relationship with their healthcare providers and let them know what is important to them. And they need to feel comfortable in doing that. And so one of the ways for patients to really get the word out or get their voice heard is to participate in research projects that they can really illustrate what really bothers them, what they want to see improved about their lives, not just what the medical field tells them that they need to do. So I have highlighted in step 3, ask the patients their goals and priorities, okay? Because that's really what I think we should be focusing on. And then discuss the patient actions that can improve those outcomes. So help you be able to comply or follow treatment recommendations. And these I have listed, and this is really the basis for the patient-centered outcomes, is what are the patient's priorities? What are your perspectives? So quality of life, all of us want to have a good quality of life. We want to have a social life. We want to be able to work. We want to support our families. We want to be there for our families. We want to see our children and grandchildren grow up. We want to participate in their activities. And we want to feel better. As far as dialysis patients, the ultimate goal is to get a transplant. And I know we have a lot of transplant patients here. And then you want to live a long time. I mean, many of you have heard about the shortened lifespan of patients with kidney disease, especially on dialysis. And so you need to be engaged in the process to help us learn better ways to help improve your life expectancy. Now, I have listed here sort of traditional medical research that usually occurs in kidney patients. And these are things that you all, if you've been on dialysis, you have your monthly lab report, right? So these are all things that you get kind of graded on. And you know a lot of these numbers. So you want to make sure your hemoglobin is good. You want to make sure your cholesterol is good. Calcium, phosphorus, PTH. That dreaded KT over V. Everybody knows what that KT over V is. That affects how long you have to stay on dialysis, or if you're on peritoneal dialysis, you may have to do an extra exchange, etc. and then blood pressure. So those are all things in the medical community that you continue to see studies on. But unfortunately, a lot of the studies that have been conducted in dialysis patients haven't all that been effective or actually really positive results, or things that are life-changing. I think we want to focus on those things, and we want to do everything we can to improve your health, but nothing's been sort of, earth-shattering. It's not any major changes in the whole dialysis treatment paradigm. So that's why you've heard a lot at this meeting about innovation, and I think there needs to be a lot more new research and methods to treat patients on dialysis. The other important point of this, too, is that if patients are given the support that they need to be able to achieve all of these goals, the studies really don't matter. If you can't control your calcium phosphorus because you have issues getting your binders, you can't get your blood pressure medications. If you're a transplant patient, you can't afford your transplant medications after Medicare stops coverage. And so those are all things that need to be addressed and for patients to get effective treatment from the medical studies that we do have. So PCORI, I think, has really been, a big changer in the field of improving care of patients. And you've already heard an excellent background of what PCORI is. And I want to tell you about some of the specific projects that PCORI has funded, and namely a project that we have received funding for through AAKP, and that we will be soliciting your help with. I've had so many people talk to me and say, I want to get involved, I want to do more than what I'm doing, I want to help other people. And so this is going to be a great project for everyone to get involved with. As Diana mentioned, we have a grant that just got funded really a month or two ago called Empowering Patients on Choice. I'm sorry, that's not the name of the project, but it's based on some other previous funding projects, and one is called Empowering Patients on Choices for Renal Replacement Therapy. And these papers that I'm going to highlight are referenced and published in mainstream medical journals. So these are things that your doctors are reading. So the word is getting out that research needs to be more patient-focused. I've heard a lot of people say, well, I can't get what I need from my doctor or my healthcare team. They're telling me about my labs, but they're not talking to me about my personal issues, how I get up every day and come to dialysis, and how I can't work, and those types of things. So believe you me, your voice is being heard, and it will continue to be heard, but you have to get the voice out. You have to speak up. You have to encourage your other patients in your centers to come to this conference or to get engaged in whatever activities. It's great to see all of you here. You're very engaged, but there's thousands of more patients that aren't being reached. And so the focus of PCORI, and particularly our project, is to help reach those unengaged patients. So this particular study that was just published, there was 2 questions that they asked patients. One was, how do you cope with your kidney problems? And secondly, what bothers you the most about having kidney disease? And so as far as what the patients answered about coping and what bothered them the most was the time spent on dialysis. How many can attest to that? Diet restrictions, I'll probably get more hands for that one. Inability to travel, the lifelong, incurable, and fatal aspects of your disease. Lack of control. You can't control what happens. You can't control how your kidneys progress. You can't control what happens once you're on dialysis. And then the limited treatment options. So I'm sure everyone in here can witness that they've thought about all of these things as things that bother them about having kidney disease. So what they did is they sort of compiled all of the responses and came up with and used something called a coping strategies index. And so they sort of defined or categorized patient responses according to their answers to those questions. And they came up with two major sort of categories. One is engagement, meaning the patient is engaged and accepted their disease, and they're dealing with it the best they can, using cognitive structuring, problem solving, social support, and ability to express their emotions. Now, there were some patients who used disengagement strategies where they avoided the problem. They sort of said wishful thinking type things, like they really haven't accepted it. And social withdrawal, i.e. they're saying, I don't need any help, I can cope with this, I'm not going to worry about it. So as far as what types of responses, according to the types of patients, the ones who didn't have a lot of other chronic conditions, i.e. they didn't have heart disease, diabetes, heart failure, they were more likely to rely on engagement strategies where they had positive responses to their disease. Those with kidney disease for at least 6 years or less were less likely to use disengagement, meaning they were more engaged. And that makes sense, right? The longer you've had a problem, you learn to accept it. So really the patients who had just been diagnosed within a year or so were the ones who were more likely to be disengaged, as well as chronic kidney disease patients, advanced stages 4 and 5, before they got on dialysis, because they just haven't accepted the reality that they have a kidney problem. And that's why it's so really good to see people here at this meeting wanting to learn about chronic kidney disease, because it is something eventually will progress. And the best way to slow that progression is to deal with it early rather than late. Some of the engagement strategies were, I can take care of myself, I accept it, but I'm going to keep going. I'm going to follow the doctor's orders. I'm going to rely on my family and friends for support. So those were all the positive engagement strategies used. The authors in this paper concluded that patients with those attitudes, which I know is most of you in this room, suggest that these patients would be responsive to opportunities to improve self-reliance if they had more structured and systematic support from healthcare providers and social services to address their quality of life, and thus better patient-centered health outcomes. So they took this as a way to say, we need to do better to give the patients what they need. They do want to do better, but they need more help. They need more support from their healthcare providers. Now, for the patients with disengagement issues, these were patients who again said, I'm okay, I don't need help. Can you guess what group of patients were more likely to have these strategies? I'm talking about not necessarily disease process, but types of people. I'll give you a clue: male versus female. Right. The males were more likely to say, and we all know this, right? We always say this, that the men may not want to go to the doctor like they should, those types of things. And so they were more likely to say they didn't need help, they would be okay. But the point is if you knew what those patients' coping strategies were, that you could better direct them to get the help and support that they need. So their summary was that the providers could be more vigilant and proactive in suggesting engagement strategies, such as encouraging them to go learn more about their disease, participate in any type of support groups that are available, and talk to other patients. And that's going to be sort of the focus of the rest of my talk, is about the importance of patient and peer mentorship to help patients adjust and have appropriate coping strategies. So solutions to improve coping skills, first and foremost, is referral to other patients with similar experiences. I can stand up here all day and talk to patients about their disease, but I have not personally gone through it. It will help you to talk to someone who actually has felt the way you feel. And so that's the whole point of our project that I'll talk a little bit more about. Another thing, and I actually got one of these suggestions from one of you in one of our lunch groups, is giving education at the proper time, that you have a proper mindset. So if you wait until a patient is on dialysis and they're in-center dialysis, they get comfortable with someone else taking care of them, they're not as receptive to hear about home dialysis, or that they would now be responsible for doing it at home. So really the opportune time is before the patients start dialysis, if we're talking about trying to get on home dialysis. And then also other things about dealing with their disease. A lot of times patients get on dialysis and they give up. And they just say, oh, I just feel bad, I can't do anything, but if you're prepared before you start dialysis, maybe you might do better on dialysis. And then more time and effort focused on meeting patient needs, a trust factor. You have to be able to trust your healthcare providers that they have your best that they are concerned about you as a person. Better communication. I've heard several stories about sometimes the patients don't feel comfortable talking about all of their problems in the healthcare setting. And also even in the dialysis unit, you're sitting next to other patients, and then, people come and ask you questions, and you may not want everybody else to know your business, right? So those types of things, just the whole way that the whole dialysis sort of process is set up is not ideal to help patients really address issues they really need to. This was actually a quote from a patient at one of my centers. We did a study and asked about their preferences about dialysis, and they expressed a preference for a more personalized care and pushing back against a dialysis practice that's designed to be automated for maximum efficiency. And this statement was so enlightening to me. They said that the patients said that while they're dialyzing in their chairs, they're 6 feet apart, and you could hear the same thing discussed with each patient. They're going over their labs, etc. And they described it as a drive-by assessment. And then you move on to the next and the next, like a one-size-fits-all approach. And then if I really think about it, that's what goes on in a lot of dialysis units. And the patients need more time. They need more privacy. They need more one-on-one approaches to really improve their care and make them feel more engaged as well. Now, I just have a slide about home dialysis. I know there's several home dialysis patients, or you've been on home dialysis. And this was a paper that we published a couple of years ago. And it's just showing you sort of the national rates of patients on home dialysis. And this is particularly, the first column is PD, is peritoneal dialysis. And then the third column is home hemodialysis. And we know in general that home dialysis across the United States is really about 11 to 12% of the whole dialysis population. But you can see I have it broken down according to race, and the African Americans are at the bottom. So they're 6% likely to be on peritoneal dialysis compared to 11% of whites, and then Asian and Hispanics are in between. And then for home hemodialysis, I mean, overall, I would say the population in the U.S. is about 2% of people on home dialysis. It's harder to determine any disparities in that because the numbers are so low. So what about home dialysis? What about types of dialysis? So PCORI has a project, the Empowering Patients on Choices for Renal Replacement Therapy. So they asked existing dialysis patients, did they choose the type of dialysis they were on? And so when they asked the peritoneal dialysis patients, 95% said, yes, I chose this type of dialysis. And they cited reasons why they chose peritoneal dialysis. Well, I hear a lot of bad things about hemo. I don't want to do that. I can have a better quality of life. I can work, and it's more convenient. For the in-center hemodialysis patients, 47% said that they chose to be on hemodialysis. So that means 50+% were just told or referred to an in-center dialysis unit. Okay, so that's a major problem because they didn't really have a choice. And they also cited the reasons why they stayed on hemodialysis because they were afraid of getting infections with PD, and we know that that does exist. But many of them didn't even know they could do home hemodialysis. And then they got comfortable in center, so they felt like they just wanted someone else to do their dialysis. They didn't want to be responsible for it. So again, it sort of speaks to the fact that these patients need to be given a choice earlier for their therapy choice. Now, in contrast, this is a survey of doctors and nurses and asking them what type of dialysis they would choose if they had to go on dialysis. And you can see 90% of them chose home. Okay, but yet 50% of the in-center patients are told to go in-center. And so these are things that we definitely need to improve on and get the word out and get the patients educated about what their choices are. They cited important factors in choosing the type of dialysis, obviously independence, flexibility, and quality of life. Now, this is a scale that you all can use This is on the web. The website is choosingdialysis.org. Okay? And if you're a nurse or a healthcare provider, especially in your clinics, or you want to or talk to other patients about what type of dialysis they should do, this is a good tool, and we're going to be using this also in our PCORI project. So some of the questions are, what matters to me for this decision? And so one thing is having someone else in charge of doing my dialysis. So if you choose that, you'll move that bar in the middle to the right. If you see your healthcare team, if you want to see your healthcare team often, if you have ability to go to work or school, so you really rate your priorities. Having a flexible schedule, having social support of other patients. There are some patients who like to go to dialysis. It's a social event, right? And there are some people that's important. But there's other patients who may want to be flexible, they want to work, etc. They want to travel, and they want to provide care for themselves at home. So basically, you would rate each of these questions, and then the bars on the right are going to tell you what's a better fit for you. So it's really a decision guide that takes into account your preferences and not just what the doctor tells you to do. And then you decide, I think I'm a better fit for home dialysis. And then you tell your doctor or nurse that that's what you want to do. And that's the website there, for choosingdialysis.org. And that's the paper reference. Now, how do we get more patient engagement? Obviously, all of you are here because you're engaged, but like I said, there's patients who need to be here that aren't. So we definitely need more patient-centered research that addresses patients' concerns and includes the patients in the design of the studies, i.e. PCORI. We need to develop more patient advocates and ambassadors to mentor other patients with similar experiences. And we need to have patient focus and support groups to really get your opinions about what should be done. Now, I want to highlight one statement I said, with similar experiences. So what we learned, or what was learned from that coping strategies index, that patients have a different level of coping depending on their experience. So those who have been on dialysis for a longer period of time cope differently than those who had just been on for a year. So our goal is to match patients with those types of things in mind. Also, home dialysis patients cope differently from in-center patients. So we want to match patients as much as we can with a person who has similar experiences so that they can actually more realistically be an effective mentor. So PCORI and AAKP, as Diana mentioned, our project is enhancing patient engagement through peer mentoring to improve outcomes in chronic kidney disease. So now, this study is going to address the spectrum of kidney disease. So we have advanced chronic kidney disease, stage 4 and 5. We have dialysis patients, in-center, home, and then we have transplant. So it's going to encompass the whole spectrum. And so we're going to deal with coping strategies, matching similar patients, and then we're going to also focus on education about home dialysis and transplant. So I've already talked to a number of you who want to be involved, and we definitely will need your help when we get the study formally studied. The study is going to focus having a steering committee. Some people can be on the steering committee, and we want it comprise majority patients because, again, it's a patient-driven study, and we want you all to be involved with the design and how we approach patients. And we're using the AAKP ambassador sort of platform to conduct this study. And so many of you are already ambassadors. We're planning on training more ambassadors specifically to be involved with this project. And we want to learn the best practices to reach the unengaged patients. That's really the whole point, is the people who need to hear this are not hearing it. They're not getting, the information that they need. So we want strategies to reach these patients. And so by using the AAKP ambassadors, we're going to have you assigned to a number of patients, and it's going to be your responsibility to contact them. You can meet them wherever they are. We can't expect the patients to go to a seminar or go to a class. We want to meet them where they are because we want to reach them. And so we're developing all of these processes, and we want everyone's input on how to do this effectively. And then, so again, for the patient is in the center. And that's what I think we need to all remember, especially the medical healthcare profession, and I applaud PCORI for realizing that and supporting studies so that we could better reach patients. And then this is the last slide. Patients engaged in their own care have better outcomes, and there are several studies to support this, and that's the message we want to get out. I have my email address there for you to contact me if you want to be involved or have questions about any of this. I'm happy to answer, and I think we're ready to open it up for questions. Anything you want to ask is fine. How much time do we have? 15? About 15 minutes, so yes.
Good morning. A little small background about me. I am a retired veteran, and I utilize TRICARE. All of my services, dialysis, and transplantation was through Walter Reed. And ever since I became an AAKP ambassador, I realized how privileged and so privileged that I've been with my care and treatment. So the individuals that I will encounter as an ambassador did not receive the same privileges, did not receive the same care and expertise and concern that I received from my nephrology team and my transplant team. So when I encounter individuals, which is odd to me, because you stated that most individuals who have been on dialysis under 6 years are most likely to be disengaged, but I have noticed that there are a lot of dialysis patients who've been on dialysis longer than 6 years, who's fed up with it, and they're ready to just give up and die. I'm just being honest. So when we encounter patients like that, how do we address that? When we talk to them and they're like, well, if my nephrologist didn't tell me about this, then I don't need to know. It's not something that I need to worry about. Why should I dwell on this when I'm sleeping, and breathing renal failure and dialysis all the time? So as an ambassador, how can I approach that with a fellow kidney disease patient?
No, that's a very good point, and that's why we want to do this project. So, because we recognize that there are patients who have different strategies, and some are disengaged, and those are just that particular study that had that. But yes, I know that there are some patients longer than 6 years who are fed up, just like you say. So really, that's the challenge, is how do you reach these people? I do think it will take more of a patient rather than me or some other doctor doing it, and that's why we want to now embark upon this peer mentorship. And then, so we need to ask them, why are they so disengaged, and try to address all those issues. That's the whole point of this, is to find out why they have given up. Not just say, well, you need to do this and that, but really deal with whatever the problem is. And you know, obviously there's some patients who may need, I think I had that on one of the slides, they may need therapy, you know, they may need a referral to some other type of something that we can't provide for them, you know. That's a whole, exactly. But I'm going to be leaning on you to help with this, okay? Okay.
Hi, thank you. My name is Michael Middleman. I'm from Philadelphia. You guys are tall in here. This is, this sounds amazing. I'm a PCORI ambassador at the moment already. I wondered if you could, they have their meeting, you know, in about 2 weeks, if you could address the fact that, is there a backup plan in case PCORI doesn't get reauthorized? Because the work seems so important to continue to do, even if that doesn't happen. I hope it will get reauthorized, obviously.
So good question. So when you're here on September 18th in the morning, there's going to be, we're doing an advocacy day just, so it's that morning before the PCORI annual meeting starts, so I hope you'll be able to participate. If PCORI were not to be reauthorized, the worst case scenario, what would happen is that they have the funds to finish out the projects that they've started, but then it would essentially go away. But that, I think that they have predicted that they would still have about 2 more years where they still would need to have the doors open to complete the projects. It's 2 or 3 more years to complete the projects that they've started. Now, I would argue, though, that, you know, and I mean, this is, and congratulations to Dr. Lee and everyone here. I mean, you have, when I talk about connecting the dots, you are connecting the dots. Like, this is exactly the kind of research that was hoped for, that PCORI would be doing to connect the dots between people getting good care and care that matters based on what we know patients are experiencing in their real lives. So, you know, if we can keep telling this story, I have a lot of confidence. When we go to the Hill, we have not hit a lot of members who would say, we are not going to reauthorize PCORI, we don't believe in it. The real issues that we're hitting are, should it be funded through this tax, right? Or should it be an appropriated thing? Is the Board of Governors right? But they do, some of the members do come at this with what has PCORI done in terms of its impact on the healthcare system? And because PCORI's projects are just now coming online, and that dissemination piece of the puzzle that Dr. Lee is working on so hard, that dissemination piece of the puzzle is still happening, and there isn't, I hate to say, there's not a lot to show for it yet from PCORI because these projects are just wrapping up. But that's, I mean, what we've been arguing is that's the next 10 years, right? The first 10 years was about getting the right projects done, the patient engagement, making sure that they're measuring outcomes that matter. And now the next 10 years is really in that translation piece into healthcare. So I don't know, maybe I'm being a Pollyanna, but I am optimistic that PCORI will get reauthorized. Whether it gets reauthorized for 10 years, fully funded, those are, I think, open questions. But we aren't hitting the kind of controversy on the Hill that we had feared. So, fingers crossed. But we do need a lot of advocacy. We still need people up there telling this story. You have a great story to tell, perhaps better than, frankly, a lot of other conditions, because PCORI's done, I think, a really nice job of creating a whole portfolio of projects that really fit and tell a story about how that then translates into helping policymakers to make good decisions, thinking about home dialysis and all the work that's been done at CMMI. And it's information that I'm sure is very helpful to insurers when they think about how to care for kidney patients.
Cool. Thanks.
Bob Friedman from Brooklyn, New York. First, a comment, if I may. Amongst the choices of dialysis, one factor that may be very relevant to a lot of areas is the physical space for home dialysis. Those of us in urban quarters where we fight over closet space, people may be reluctant to use very limited physical space, also to have their apartments generally turned into sick rooms. It affects the entire family. and that may be a critical factor. I see people in rural settings that are more able to set up dedicated treatment space in their homes. Second point, first of all, I'm very glad to hear, Dr. Lee, your very holistic presentation of the diversity of dialysis patients. However, I think you mentioned time as a factor. Have you given any thought to the stages of people going through dialysis, given the physical, neurophysiological, and psychological toll? Certainly as one stays longer in dialysis, one's perspective on engagement and choices evolves, and that also suggests, as you briefly mentioned, therapy, but I think it's necessary to A, continuously evaluate the capacity of dialysis patients to make both informed decisions and choices, and B, to provide timely intervention at various stages to be able to empower them to engage.
I agree totally, and I don't even need to say anything else for that. That's perfect. Yes.
Hello, so my name is Jonathan Haydak. I'm also from New York, but I did do a almost 3-year stint in Georgia when I was going to graduate school at Georgia Tech. My main clinic was an Emory clinic, and so I have some questions on getting patient involvement, especially in urban and rural areas. So when I was at Emory, I can't say that there was a huge focus on these patient-centered involvement and outcomes and to that. So implementing these types of things in rural areas where you barely even have the medical infrastructure for heavily intensive therapies like this, as well as urban areas where you have just significant populations of minorities where there's just a barrier between language and culture between the doctor and patient, that seems to me to present a big barrier to incorporating these things. How would you get past that?
Yeah, no, excellent point. So our focus initially and what we have funding for is to focus on the urban area in Atlanta, because that's where I'm based, but the plan is to learn from our experiences and expand it to other regions. So yes, some of the methods that we're going to use don't require direct patient, one-on-one as far as in person. We can do phone calls, we can do Skype, a lot of different things. Of course, a challenge for that would be the patients in the rural areas may not have access to internet and things like that, video technology, but that is one of the goals, to develop this process and then to reach it into other areas that are underserved. Our focus is the African American population, or underserved areas of patients who are not normally engaged in their care. So we will use this as a model to really reach out to those areas. Now, we do have telemedicine now available, and that could be also a platform. One thing we're doing at Emory, this was probably before you were there, we have a telenephrology program where we reach patients in rural hospitals in like South Georgia, hospitals that nephrologists don't really go to, but those patients are in local clinics, but they rarely see their nephrologists, in those clinics because they're so spread out. And so we do have a mechanism through this telemedicine platform to really have outreach in those areas. So that's something we could also tie into this project later. Okay. Thank you for your question. Yes.
Good morning. I'm Dr. Jean Wright from Detroit, Michigan. We have the Virtual Dialysis Support Center, a community-based nonprofit, and we started our peer mentoring program about 3 years ago. So now we have a database of a couple hundred people who have approached us or we have seen at lobby days and said that they wanted assistance. And my question is, how can we involve them, or what would be the incentive? How can we approach them about becoming involved in the research?
You mean the persons doing the mentoring or the patients receiving the mentoring?
The patients receiving the mentoring.
Yeah, that's definitely a challenge. And So for me, I'm the medical director of, we have 4 clinics, we have about 700 patients. And, you know, I'm gonna just go to each patient because I've established relationships with them and encourage them to be involved, explain to them what we're doing so that they understand. Make sure they know the time commitment. We want to try to make it convenient to them. You know, do it around their dialysis schedule if possible. And make sure they have, you know, adequate resources to get to whatever they need to get to as far as whatever mentoring programs that we have going on. So I do believe, I think we're going to be great with ambassadors. There's a lot of people interested. We're going to have focus groups where we will give some incentive for them to participate, like, you know, a gift card or something like that. But I think the biggest challenge is what you say, is getting the patients to sign up for the mentorship. And, you know, and that's where it's going to take, I think, similar like patients talking to them to tell them how beneficial this could be for them.
Okay.
Thank you. Any insights you have from your experience, I'd be happy to listen. Okay, okay. Are you coming for a question? Yes, okay. Yeah, this will be the last question, yeah.
Good morning. My name is Karen Solomon Edwards, and I'm from Michigan. And my question evolves around the practice of a nephrologist. In the last couple of days, I've attended some of the workshops or sessions that you've led and have been impressed with your hands-on take. Now, during the 5 years that I have been going through this with my kidney disease, I've seen an array of nephrologists. My experience is that many of them were not patient engaged as I felt they should. And at the Nephrologists Association or education, is there CEUs addressed at how nephrologists and those that provide care to patients, how they can be more sensitive and patient engaged to the patients?
Question. And it's the most important, too. Well, I can say that through efforts such as PCORI, and I made a point of showing you that those studies were published in mainstream journals. So the doctors are reading these. So that's one mechanism, is getting these types of patient-focused studies out into main journals that the doctors are reading. I think there is, do you have an answer too? Because this is a hard question.
This is the dissemination challenge and the translation challenge. It's interesting that you asked this question, because I was engaged in a discussion with a group here in DC recently about shared decision making. And when we talk about shared decision making, you know, shared decision making should not be a controversial concept. And I really enjoyed the slide that Dr. Lee had about the tool for, you know, having how patients can say, well, these are my preferences, and then that would help patients then make a decision. I mean, but the first things first, clinicians need to be trained in how to communicate with patients. And this is a priority that a lot of groups have here related to shared decision making, because there has been a tendency at the agency to, with some of these new national coverage decisions on various treatments, to try to mandate shared decision making, and you can't do shared decision making well if the clinician's not trained to do it, right? And so we've been trying to figure out how do we get shared decision making done in a way that works? And and it starts with, we probably need better programs in schools to train doctors to talk to their patients, maybe some continuing medical education. And also to make sure that the tools that are being used are good tools, because there are some shared decision-making tools out there that don't necessarily incorporate the best of information, and are more intended to drive people to less expensive care than they are to the right care. And so we've been very focused on that from a shared decision-making perspective. And I applaud PCORI because they've been funding these kinds of shared decision-making tools as a result of their research to try to get them then disseminated into practice as part of their translation strategy from research to practice. And so, but it's a tough issue, but it all starts with exactly what you're talking about, which is I think we need to be doing a better job of, as health systems, of emphasizing the need for doctors to be trained to communicate with their patients. And if not the doctors, then their nurses or some other person in the office. But I would encourage you to stay engaged on these issues, and I think PCORI will be a really big key piece of the puzzle as this concept of shared decision-making and how policymakers can encourage it constructively evolves. I do think it's an evolving issue that PCORI is part of.
Yeah. And just to add a little bit more to that, because it is a really difficult, question to answer. So you heard about CJASN last night when we presented an award. So CJASN is the clinical journal from the American Society of Nephrology. So nephrologists are reading that, and they've implemented the patient voice editorial. So they're taking those clinical articles and they're layering it with the patient voice. So there is an opportunity there to provide that patient insight to the nephrology community. And then additionally, ASN also hosts Kidney Week each year, which is attended by upwards of 13,000 or so nephrologists across the U.S. as well as international. And this is the first year that patients are going to have a very large role in Kidney Week. And Paul Conway, AAKP's past president and chair of policy and global affairs, is actually the co-chair of Kidney Week this year, and it's being hosted in D.C. in November. And so we'll have a lot of representation from AAKP ambassadors, AAKP board members that will actually be part of the agenda and the discussion and the schedule throughout the week. So that's really exciting, and it's an opportunity to reach thousands upon thousands of healthcare professionals, and they do offer continuing education credits. So in a way, professionals have to be there, and then they get the opportunity to hear from patients. And then AAKP also partners with ASN on their STARS program during Kidney Week, which is students, residents, and fellows that have expressed interest in nephrology. Maybe they haven't chosen what path they want to take. ASN provides scholarships to Kidney Week for these individuals, and on the closing day of the program, these young minds convene for a farewell lunch. And for the past few years, AAKP has been at that lunch, and we have had a patient panel, and actually Dr. Lee participated in it last year as well, where it's an opportunity for us to reach those individuals and maybe change their way of thinking and change how they approach patients and how they share information, and just on a more personal level. So I think there are opportunities out there, and hopefully we can grow that.
I'm Danielle Herrmann, and I'm stage 3 kidney disease. I lost my right kidney to a very rare tumor, so we don't know what will happen with my remaining kidney and my trajectory. I am a medical and clinical social worker in the state of Maryland. I'm in my 60s, so I was trained in patient and community relations in the 1990s at Stanford Medical Institution, and we were having this exact conversation about the training of healthcare professionals and the sensitivity towards being able to empathize. And as a allied health professional, I guess that's what I would be, having worked alongside nephrologists and all sorts of specialists and integrating behavioral health in primary care settings, my concern also is about compassion burnout. that happens to individuals that are providing the care, and the fact that we have individuals like myself that have sustained medical trauma, and then we have other individuals that are suffering from secondary exposure to trauma. So I can speak also as a psychotherapist, working with individuals with medical trauma, and then also working with medical providers that themselves are really struggling as well. So I would really love to see looking at the dialysis unit culture and the ways in which there could be support for not only the patients and the ambassadors coming in, but also looking at the staff and what we can do to support changes in that arena so that we're looking at it in a more comprehensive way. And is that something that's being looked at this point?
I'll just say that's a very important point. I think sometimes I get burned out, actually, just trying to take care of all the issues that are involved with our patients and the staff. We have so many patients and working long hours, and I do think there needs to be emphasis on that as well. So I agree with you.
Okay, and I can provide you with some information and programming ideas for that. Be happy to.
Okay, thank you.
Well, thank you, everybody. This has been a great discussion. Thank you, Dr. Lee. Thank you, Sarah, for joining us this morning. And we'll go ahead and get started with our next session on AAKP Action Alert. So we'll bring up Ed Hickey, AAKP board member, secretary and chair of our Veterans Health Initiative, and Paul Conway, our past president and chair of policy global affairs. And then Aaron Kale, Director of Stakeholder Operations, and Richard Knight, our AAKP President.
So here at our last session this morning, what we're going to do is we're going to go through a quick recap of a couple of different items. And then this session, since it's the last one, is a little bit more informal. We encourage you folks to ask questions. You've had 2 days of discussion on policy. You've asked great questions. We've drawn into a lot of the details on disease types, on advocacy initiatives, but this is your chance to learn in a pretty candid way some of the more things that are going to be on the horizon for 2020, things that you'll see online and social media, you'll see in our magazines, you'll see at our events. But it's a chance for you to become familiar with some of what's coming down the pike here. Very briefly, let me go back here. So our mission, obviously, you folks have now had this drilled into you. We educate patients, we advocate for innovation and patient choice and care, and we're actively involved in defining patient engagement. The previous panel that you just listened to about PCORI, fundamentally important that AAKP is engaged on the reauthorization of PCORI and what that means. Consider our front office and our board and those of us who are doing policy as kind of the navigation system of timing for when to weigh in the patient voice. We're pretty good at that, but we'll be asking everybody in this room at the correct time to weigh in to have the maximum impact for reauthorization. We're divided into 2 major centers for our operations. We've talked about this, Center for Patient Research and Education. You can see all the different things that kind of rack up in these 2 areas. Center for Patient Engagement and Advocacy, and this is a lot of our Hill operations, a lot of our DC policy thing, but also a lot of the training that you folks have available to you to become better at articulating your opinions and your voice as patients. And then here this morning, we'll talk about different things that you can do, but the basics of it, how to join, how to encourage other people to join, and what that means, and what being a member of AAKP practically can do for you. Also, Erin, who has her own slide, her own meme here. That is Erin. And she'll talk a little bit more in detail about how folks can become ambassadors and what that means for training and skills. And she'll also talk about where we are on our program and path for 2020. Hill Days, I think we'll all be able to speak to this. Richard and Ed can talk about the impacts of Hill and Aaron in terms of organizing it. Social media campaigns, both Aaron and Diana can get into the details of how you can be active from your seat or from your house or from the comfort of your bed while you're watching movies or something like that. It's very easy to be high impact. And lastly, but most strategically, I think, Ed Hickey, who is heavily involved, as I referenced before, in the decade of the brain in the 1990s and was the architect of much of that national and international policy initiative, is on our board. We're very lucky to have him, and right now we're in the process of laying out the architecture for Decade of the Kidney, which we officially launched with a soft launch in Washington in June, but you're going to see this everywhere. We have our trademark underway, but this is going to be an international effort and a national effort, and Ed will get into the details of that because it's going to have a lot of patient and industry think tanks and universities underneath that. So with that, let me back up here, and we'll go ahead and start on a couple of different things. Probably one of the things that would be most interesting for folks are the basics on how to join. And Diana, why don't you go ahead and talk about that, and also Aaron.
So it's really easy to become a part of AAKP. There is no barrier to entry. You can join online at aakp.org. We offer free membership for patients, living donors, family members. We also have membership for healthcare professionals, physicians, institutional members. We also have life membership for those that are really dedicated to supporting the organization. And for the professional memberships, it's really an opportunity for them to utilize AAKP's resources and be kept up on how policy and programs and issues are affecting patients, so that way they can utilize AAKP as a resource for their patients. So it's really easy to join. As part of your membership, you receive a lot of information. So you have access to our website, which I'm really proud to say we launched a redesign of our website, so please check it out and let us know what you think. We feel it's great and really user-friendly. You receive our bi-monthly magazine, AAKP Renal Life. We have a number of electronic newsletters that focus on different topics and stages of kidney disease, so it's your choice what you want to receive or what you don't want to receive. And then, of course, we keep you updated on the latest educational materials AAKP is creating and disseminating, the programs that we host, such as our Global Summit, our Policy Summit, convention, if we're going to be at a health fair in Texas or doing a workshop with a partner such as ANNA in Chicago. You know, we keep you up to date on opportunities to get involved in your community, as well as sending out information on policy and advocacy issues when we really need your voice join with ours.
As one idea of how important it is to expand membership, Richard, can you talk about the Kidney Precision Medicine Project? You folks watched a panel about this on the first day. That's National Institutes of Health has this project underway, but the timeliness of it is critical because of what they're doing nationwide.
Yeah, okay. The Kidney Precision Medicine Project it's something that will tell us a lot more detailed information about the kidney. Kidney research is about 20 years behind cancer research. And the gentleman who we gave the award to last night, Paul Kimmel, he's intimately involved in that, got myself involved in it, and several other AAKP ambassadors who may still be here in the room. And one of the things, or the phase that they're moving into now, is that they're going to begin to draw tissue samples via biopsies. Now, many of you in here may have had a biopsy, and you know how much fun that is. But one of the things that the biopsy will do is that it will give them much more information. And the whole concept of precision medicine, where you gather detailed information about a population, in this case, we're gathering detailed information about kidneys, so that in the future, 5, 10 years, quite frankly, when you go to your doctor, they will have access to the results of this information, because it's not kidney disease, it's kidney diseases. And there are so many different, I'm going to say, strands of it. What you referred to is something very rare, but you have it. And it would be helpful if you went to a doctor, and there are other people in the world who have it, or in the United States, and if they had information on those other people, as well as yourself, that might help you. And the whole objective is to give the right remedy for you at the right time. And one of the things that they're doing now is that at various sites throughout the country, they're looking for volunteers to participate. It is something that we want you engaged in for a long period of time, like a 5 to 10 year effort. And it's not really that intrusive because they have a set schedule where you will participate but provide them with some information. I know many of you participate in focus groups, so think of this as a long-term study, which it is, and all of this information will be categorized. And there are so many researchers on this project, and including the patients. On a regular basis, we get training on different aspects of it. Omnics, we got the pathologists in there, they've got the people creating the databases. And so just like the patients, there are many researchers who don't understand another branch of the science that's taking place. But what Paul was referring to is the opportunity for many of us to participate in this if you choose to, because again, it is a long-term project. And we have different sites, I don't know the name of it, I think it's 6 different sites throughout the country.
And there's 6 different collection sites. And in addition to, if you're interested in participating in the research and donating samples, that's one opportunity. But the other thing that the federal government has done, and Richard's been right in the middle of all of this, is that NIH has come to AAKP and said, at each of these collection sites that's happening around the country, we want to make certain that patients are on the advisory boards for the collection sites and looking out as advocates for the patient interest in terms of the protocols and in terms of the reporting back. And that's one of the things that they come to you on, asking patients that might be interested in serving on advisory.
We have what we call community advisory boards. And again, we just want to make certain that in the past, much of the research that has been done has simply not included everyone. Even precision medicine, forget about kidneys, but just precision medicine in general. And so they have an effort now up at NIH where they're doing a much more broader effort to bring in. The population consists of a lot of different types of folks. It won't be effective unless the data and the information includes everyone. So that's the focus right there. So we're establishing community advisory boards. One part of the country, you may have a very different community than another part of the country. But the point is, through these community advisory boards, we want to be able to help the researchers outreach to the community so that they can get people that are reflective of that population in that particular part of the country, so that when this all does come together, it's just going to take where we are, our understanding of kidneys, it's just going to take it to a much higher level. And with the push that's going on now, with the executive order, this would do nothing but help the nephrologists do a much better job. It'll be a tool that'll be used by nephrologists. There's a lot that they do that they have to do now. And the most experienced nephrologist can look at something and look at 10, 15 different options perhaps. But when you get technology and a computer involved in it, you may be able to look at as many as 100 because it can just scan and based on the parameters that are being set up. So it's a very interesting and exciting project. The same thing with the APOL1 project. A lot of things going on. We want you to be aware of that. So should you choose to, or you hear about it and think about participating, you can make a decision based on having good information. And again, we can make that information available, and I think that we've provided to them information on patients that we have within the sites. And some of you may be on that list, I forget all the sites, but you know, this up in New York, out in Texas, just spread throughout the country. And they will be expanding the sites as the project grows. Paul actually serves on the external evaluation panel, with broad oversight, looking to make certain that it's a government contract, to make certain that they're staying on task. I'm co-chair of the Community Engagement Committee, and we're charged with the responsibility of having clinicians, patients be engaged and at a high level. For example, we help them come up with the informed consent documents and other things. Patients have been involved in all aspects of it. The patients have had to learn, I'll use the term become familiar with, because some of the information is very, very detailed. Quite frankly, we won't be experts in it, but at least having some idea. And we've had the webinars where they take us through it, and as I tell them, post them, because I'm not the brightest bulb in the patch, and I'll sneak and look at it after hours. I may have to look at something a couple of times to understand it. I'm not as bright as some of you guys, but I have no problem looking at it a couple of times, and even looking up the definitions, the meaning of all the words that they use. I have to do that. So I'll turn it back over to Paul, but again, it's just one of the things that we're engaged in, working with the civil servants to make life better for all of us.
Richard. So again, practical terms, if you hear Kidney Precision Medicine Project, you want to be engaged either as a patient doing samples, or you want to be considered for advisory boards, contact Diana Kleins. We'll patch you into NIH immediately so you can get considered for that. On the ambassador program, we've kicked the term around. People are all sprouting up different ambassador programs around the country, which is flattering, obviously, to Erin and to our AAKP patients. But in terms of how practically people can connect with you and start to become active members, do they get a T-shirt with that on it? That type of stuff. Go ahead.
Yeah, so many of you were in our session yesterday about AAKP Going Global, our ambassador initiative. And you all are really doing, taking the first step, coming here, empowering yourselves, raising awareness that you'll bring back into your own communities. And that's really the first step in becoming an ambassador. So it's as simple as emailing me. I know I shared my email and phone number out earlier. You could find me on Facebook. You can find me on Twitter. My contact information is on our website. It's really just about reaching out, saying hello, that you want to get involved. We want to make sure that you have access to all of our resources, all of our newsletters, as Diana mentioned, that you'll receive as a free patient or family member. And then we will send you a link to a webinar that you can listen to, and it'll give a lot of good background about AAKP's mission that you've heard so much about over the last couple of days, our priorities, and really just some initial steps on how to get you even more engaged. And the hope is that you will become somebody that other individuals in your communities will reach out to and look to for advice, and somebody who has some firsthand knowledge of what people are going through, and then you can continue to share and connect with others. We are launching an ambassador certification program, which will be coming sometime in 2020. And this is a way for those individuals who want to be even more involved can become further empowered and engaged. There will be several different modules that you can go through, and it will be a real certification program. So we're excited to be launching that, and we'll share more information about that as things progress.
Formulating, just so everyone knows, what is certification? What we want to make certain of is that as the nation's largest and oldest patient advocacy organization in the kidney space, that when somebody goes out and says they are a, quote, ambassador, that there's a distinction about what is a certified patient ambassador. So they've gone through the basics of, they understand policy dynamics, how Congress works. They understand what patient engagement means. They know how to access research. They know how to talk to fellow patients. So we're in discussions with a couple of different universities about how we might be able to do that either for some credit or to have some type of academic rigor brought to it. And we think that will be a key distinctive for us. No one else really does that for the patient. And we also think it might be good at some point to make certain that medical professionals also go through our certification for understanding how to actually communicate intelligently to patients. And Barry, I see you smiling. You know that's said in good spirit. Yes. but it's exciting and it's important. One thing, we like to say that we're nationwide, so if you could just elaborate on what we're going through. Sometimes we have ambassadors in a state, but as we all know, some of us get sick sometimes. We've lost some fantastic people over the past several years, but we have needs in certain states that we do not have coverage in. And the reason why that's important is on things like PCORI recertification and others, we need to be able to have a person in a state that we can work with and say, help us organize more voice from that state. So there's a list of states here, and I know that you've gone over that before, but in terms of people with ideas on who to reach out to?
Oh, certainly. And, you know, this list might change after the last couple of days, because I have received a lot of people coming up and saying they want to be involved. So we have been looking for individuals in Iowa, South Dakota, Wyoming, Vermont, and Delaware to become involved. And I know some of you have come up to me and you are in those states, and I'm ready to get you involved, so I'll be reaching out very soon. But we are nationwide. We've been expanding globally, and I'm happy to say that we will have some additional global ambassadors after this event as well. So in addition to representing your state, you will also be a national representative, and you will be invited to Washington, D.C., other meetings, some of these advisory panels and technical evaluation panels that people have been mentioning just the last couple of days. So there are a lot of different ways for everybody to get involved in speaking engagements. If you're better at writing, or if that speaks to you more, we can certainly get you involved in sharing content and writing articles for our newsletters. So there are a lot of different things, and we're looking for those people in those states, but of course we want to continue expanding throughout the country as well, and try to reach those really underserved communities. So please come up to me if you have any questions.
Or she'll come up to you. Capitol Hill. So we talk about this a lot, and just to make a very fine point here, AAKP is not all advocacy. All right, some of us are a little bit biased on that side as patients because we come out of that world. We're educators and we're advocates. Personally, I actually don't think there's much of a distinction. So if we're educating, we can educate about disease, we can educate elected officials about disease. But when it comes to advocacy, and I see my good friend Jim here from New Jersey, an expert at advocacy, very unassuming, and a powerhouse in congressional battles of many years, and you know how this works well. We need more individuals to participate with us when we go up on Capitol Hill, and to do it virtually. You can be just as powerful online as you are coming to Washington, D.C. In fact, I'd argue sometimes even more so that everybody knows most of the professional staff in a congressional office or a Senate office is not from that state, but in a local office they are. And when people run for re-election, like in 2020, the intelligence that comes to the elected official on the calculations for what issues they're going to run on doesn't necessarily come from the Washington, D.C. staff or the consultants. It comes from the ground up. It's ground intelligence from what the individual offices are hearing in the district. And then that gets filtered in. So if you have 4 or 5 patients making a comment in a local office, that goes into the concerns and the calculations of re-election. And we're not talking either party. We want this issue to be number one for everybody who's running. So that's why you'll start to see this type of messaging. But in terms of the impact and how folks can get involved, Ed or Richard, do you want to talk about the impact when patients come in with an elected official?
I'm sorry, what was that?
The impact of a patient coming in with an elected official, I mean, practically speaking.
Oh, no question. Very powerful. The fact of the matter is, as a matter of fact, the young lady that was here, Sarah, who spoke about PCORI, and she put up there Congressman Niclejo. One of the things that he said, he's a patient, by the way, for over 60 years, epilepsy. And one of the things he said as a congressman is that you don't speak for the patient speaks for himself. We want to hear from them. That message is so powerful. We have no vested interest or no skin in the game except giving them information. Now, I will say this. Any of the doctors or the professionals that go in there with you, their objective is also the same. But they are the doctors. That is what they do for their business, and that's how they earn a living. The patients, on the other hand, because they're the ones that are dealing with the disease, they tend to be a little bit more independent in terms of their perspective, and the elected officials want to hear. And the better you can articulate the message, the more that you can inform them. That's why it's such a strong team. Let's be real clear about it. The healthcare professionals are the ones that we have to defer to with respect to doing what's best for us. But to the extent that we want to communicate that information to an elected official, they want to know, well, what does the person who's receiving the care think? And how can we best help them? And in many instances, we're going to have our efforts coordinated. Many times when a professional may not feel comfortable communicating the message because it may not be taken the right way coming from them, they'll talk with us and we'll communicate the message. The objective is the same. You know, many times if you run a business, you've done something else, you could be the boss, but you may understand that it's better for somebody else to take the lead in the meeting. And so it's the same thing here. And to be effective, there's different viewpoints. Many businesses do things that are in the best interest of the business. There's nothing wrong with that. But the question is that in the best interest of the patients? So you always hear us referring to our independence. That means much more outside this room than you realize. That's why many of the agencies come to us and want to get our input and have our participation in efforts like they're doing, just like the great young ladies that visited us from CMS yesterday. They have a task to do, and they want to engage us to help them accomplish that objective. And we're going to engage everybody. We're going to engage all the other patient organizations. We're going to bring them into the loop. We believe the more, the better. So, but again, back to the elected official, powerful information, and as an ambassador, one of the things that we look for is even before you get started and come in here, go out to that same elected official. They're always going to have a local office. Your senators, your congressmen, introduce yourself. You'll be up to speed on the various issues that we're talking about, immunity suppressive, living donor act, and things of that nature, and there's going to be more coming down the pike. So it's always about learning, getting educated, and being able to articulate it. And typically, I know when Paul and myself go into the meetings, if you go into the meeting with us, we're going to let you talk. I want you to talk. We've been up on the Hill. Sharon went up on the Hill with us one time, and she expected me to do the talking. No, she talked. So next time she goes, she'll be comfortable taking that lead position. And that's what we're all about. The education process, everybody knows everything, and that makes us that much stronger.
Line. I want to ask Ed. Ed was the chief of staff on Capitol Hill, and Jim, you can probably relate to some of the after-hours conversations. So, patient comes in or contacts a congressman. Ed, in terms of practical impact, when you're sitting down with an elected official after hours and they're concerned about going through their schedule, what they recall from the day, if a patient comes in, two things: what's the impact on the elected official after they leave, after hours? And two, as a congressional staff person who's involved in political combat, what does that congressman think about AstroTurf, like corporate grassroots coming in versus an independent patient organization coming in?
Well, so there's a distinction. The first, with a patient coming in, it humanizes the issue. Instead of abstract legislative language, you have an actual person who's impacted by the bill that they'll be considering. And as far as AstroTurf and just general professional lobbyists, the congressmen and the senators and their staff are pretty hardened to strategic approaches by paid professionals. They discount them more quickly than they would the heartfelt stories of a patient who is actually impacted by the legislation. So you have to be really careful when you go in that you're direct and you're not trying to spin, because the folks there are just as good with spin as anyone else. And you lay the facts out, tell your story, and tell how you'll be impacted by the legislation. And that's the most effective. And it resonates. It leaves a mark. So at the end of the day, you'll hear, do you remember so-and-so from this city, and what can we do to help her? Or how, if this is going to impact her so negatively, why can't we change it? And then they go back and they talk to some of their colleagues, and it creates momentum for whatever direction you want to go.
Doubt behind the scenes, as skilled practitioners, these folks know the impact. Social media campaigns, I'll ask, actually, let me back up one second. Diana, if you can just talk about some of the opportunities then to plug in that are coming up here.
Yeah. So, on AAKP's website, we have our Action Center, and you can, as much as you can join AAKP, you can join our Action Center as well. Being a member, we automatically share information to you about when we need to activate you or when there's an issue that we need to add your voice to. But also joining our Action Center is another streamlined way to get alerted about current or emerging bills or pieces of legislation that are going on, petitions, when we have form letters and templates that you can personalize and send to your representatives as well. So we'll alert you to that through the Action Center. Also, opportunities that'll be coming up, as you've heard throughout the weekend, AAKP is very active on the Hill, and we join with other organizations and professional organizations, as Richard had mentioned, such as the American Society of Nephrology, the American Society of Transplant Surgeons, American Society of Transplantation, and the Renal Physicians Association, which I'm happy to see Dr. Pulmutter is president of RPA is joining us, so he can attest to the partnership that AAKP and RPA have. But we will be going to the Hill throughout 2020 with these organizations. AAKP goes independently as well as with our partners, so there's definitely opportunities to get involved. You don't necessarily have to be an ambassador to be asked to come to the Hill with us, but we will keep you updated when there's opportunities, and if there's the need for a person in a particular state, then we'll put out that communication as well. So please, keep those months in mind, and we'll send out additional information when dates are confirmed, so that way we can just increase the number of individuals we bring. And then also, we're really active on a National Awareness Month. There's, of course, many more than what's listed, but the two biggest focuses is March is National Kidney Disease Awareness Month, and April is National Donate Life Month. So with that, you'll see a lot of communication across all of AAKP's platforms, especially on social media. So when you do see those social media campaigns, you'll see a lot of your fellow patients messaging, please share those, please participate in those as well, so that way we can really make it go viral and increase the awareness about kidney diseases.
Go ahead now so we can get into a couple of details on Decade of the Kidney. And I'll ask Ed Hickey to talk about some of the experience that he had designing and launching Decade of the Brain, and how we're doing the parallels of that for AAKP, but more importantly for the much wider kidney community, including all stakeholders. Ed?
So in the 80s, the awareness of brain research had started gaining momentum, and my boss at the time, Silvio Conti, wanted to coordinate the efforts, and he was working with the National Institute of Mental Health and the National Institutes of Health to figure out how we can get focused research, focused education to help treat and understand better the mind. And the bipartisan bill introduced by Bob Michael, who was then the minority leader, and in the Senate, George Mitchell, passed unanimously, and President Bush, 41, signed it into law. And what it did was promoted public awareness of the benefits derived from brain research. And as a result of that, neurologists from around the country, a group of almost 100 neurologists, got together and decided how they best can focus their efforts on research related to the brain, and committed their own time and said over the next 5 years, these are our top 10 priorities, and over the next 5 years, we'll commit X amount of dollars and time to this research. The federal government also committed additional funds for research for the projects that they identified, and other countries around the world formed their own organizations and created their institutes of the minds, institutes of the brain. Japan created a group that dedicated $175 million to brain research. India, almost $100 million, I believe. And it just sort of cascaded, and there were a number of developments within the neurological community that were revolutionary. And there's a lot of, there can be discussion about what it's attributable to, but certainly having the focus on the brain and the research helped. And I believe we can do the same with the kidney. It encompasses all of the efforts that you've heard about over the last 2.5 days. And if you educate the staff, if you educate the members of Congress, if the dedicated civil servants in the agencies are already aware of the issues that kidney patients face, but to get it out in the public and have a marshaled effort advances the ball much better than an unorganized effort.
Talk a little bit about when Decade of the Brain was created. So you had legislative impetus for that. You had executive branch buy-in. What was the role of patients underneath in terms of pushing it out to gain acceptance?
I mean, again, so when I was speaking about the stories and people coming in, every member of Congress has, and virtually every person knows somebody who has some form of brain injury, whether it's Alzheimer's, whatever it is, someone's been touched by it. And those patients would come in and talk to the staff or talk to the congressman about what they needed. And it's a bipartisan issue, and hearing the stories advanced it even further. And it was critical. I mean, it was absolutely critical to moving it along, because it created the sense of urgency. And why do we need to do this? And you could see the people who would be affected by the programs and by the research, and say, we need to do this now. We need to help these people. Why don't we know more? This was in the 80s and 90s, and we just couldn't understand why we didn't know more. So here's the analogy,
and this is the importance of this. So in 2016, President Obama and his staff culminated about a 1-year effort with the Office of Science and Technology Policy on a White House organ summit. And tremendous work was done on that. One of our great allies is a great professional named Jennifer Erickson, who's a very passionate supporter of the president, had long-range thinking, but most importantly, her father's a decorated U.S. Navy fighter pilot who's on dialysis. And so she was staked in personally, and she had access to the president and the full confidence of the scientific office of the White House. And so Richard and I had the benefit of meeting with her, and it's kind of fun in a way, because we come out of Republican Party, she's Democratic Party, but the nice thing in that White House is it didn't matter. What mattered was that the thought and the concepts were being fleshed out with direct patient influence and impact, and a genuine sense of, we need this to continue. So then I had the opportunity to serve on the transition team for President Trump, and to take many of those things that had been talked about and make certain that it got populated with a lot of people during the transition. But this is one of the things in talking that we've been concerned about, which is, given elected office in the Congress and in the White House, it's episodic. You're either going to change every 2 years, as Jim knows, or you're going to change every 4 years. But we want to make certain that these issues ride on top of not only partisanship, but transitions. And so we think one of the best vehicles to do this is this concept. And the other reason why we think it's fundamentally important is this, because a lot of the effort that happens in Washington, D.C. is transactional. People gear up for one bill, one piece of legislation, and they plug patients in, and then that bill either goes away or passes, and that's it. Or one big initiative gets announced by a president, and that president leaves, and there's no guarantee it continues in terms of concept and content. But we want to make certain that none of that intelligence is lost. We want to make certain that all of that patient effort is cumulative, no matter what the issue is. And if you do it underneath a larger framework, then it continues no matter what the turbulence is down here. So think about July 10th. Major accomplishment, executive order from this administration. 18 months of hard work by all the stakeholders in the kidney community. Front-loaded with a lot of patient comments, much of that from AAKP, and we were very appreciative of it. But 2020 is an election year. If things change, those concepts in that executive order cannot fall to the wayside because many of them are based on innovation and science, which benefits the private sector and people working on solutions for us. So that's what we're looking at. You'll see a whole series of announcements because when this comes together, there'll be a tremendous number of stakeholders that we're already talking to, major universities, think tanks, opinion leaders in the media and in other industries like entertainment. But you will see a series of announcements coming, but this will all be fueled by many of the platforms that our organization and others have created to keep the patients underneath it and keep it moving along. At this time, what I'd like to do is stop here. We've given some more detail, but any questions or comments that folks have, because at these conferences, we're gleaning information all the time, but this is something before Richard closes for the day, that if there are any questions or comments on anything that you've heard here today, these are the folks that take time out of their life on a weekend as pros. So if there are any questions, feel free to ask. Go right ahead. It's Paul.
Hi, Paul. I'm Natalie Kelly. I'm from the Bronx. I wanted to also talk about the college-level ambassadors. I'm a pre-med major now, and I was wondering, could possibly we start something in the college level, and then that can transfer into an AAKP-led program?
So I'll turn this over to Aaron, but one of the things that Diana referenced was we have a very close partnership with the American Society of Nephrology. You saw Zach here. But for the past several years, I think 3 or 4 years, AAKP during Kidney Week, all of the young doctors or potential doctors, all the folks in college and medical school come together. It's called the ASN Stars. These are the folks that ASN wants to become influencers in the medical world. They're all together for one big luncheon. And at that luncheon, the entire event is run by AAKP patients. They're the ones who speak, they're the ones who stage the event, and they are the ones that stay behind and meet these doctors. And over the years now, it's been, I think, 5 years, we've had doctors who have come up to us, and I don't remember everybody, but to Richard as well. And last year with Ed was holding court with a whole bunch of former Marines. You know, there's a saying that a Marine to your left, a Marine to your right, sleep well tonight. Yeah, that's exactly what it was like last year, because you had a lot of folks that were veterans who were in medical school. And over the years, people have come up to us and say, we remember those comments at STARS. It made me a better doctor. It made me get through the nephrology program, which was X number of years. So that's one of the things, that's one of the target audiences that we will be talking to for ambassadors. But Aaron, on the college level.
Oh my gosh, I'm so glad that you mentioned that. And I'd love to talk to you if you're sticking around for a little bit afterwards. But that would be fantastic. I was just talking with somebody about getting into high schools and just educating, because a lot of people do not understand what kidneys do, let alone what kidney disease is. And then to provide them with the tools to share their story. So I think this could be a really exciting partnership, and I would love to talk with you and brainstorm and see how we can work together.
She mentioned high school, so hopefully folks here got a chance to meet a young rock star. Her name is Stephanie Murray. or Stephanie Murphy, my apologies. And Stephanie Murphy has been with us now for the past year, and she's very committed to the organization, just graduated from high school, president of her senior class, leader in everything. She's a student boxer. You folks would love her. But she has come to AAKP because her father was a U.S. Marine, works in nonprofit. I know the Marines are dominating here. Navy better get its act together, I think. Oh, well, I tell you what, we'll stand aside, except for Ed. But the point of it is, a family that's been impacted, a veteran family, and the high school daughter is interested in how to become more engaged because her dad is looking at the issues that we all are going through. And the father's, he doesn't know how to explain his daughter's activism, but it's intense because she's committed to the bigger cause. She's the type of person that, as you're looking at an ambassador level at a young age, she wants to go into pre-med and she wants to be engaged with patients, you know, because she's helping take care of one. So.
Thank you. I'm from Missouri, and I've been coming to these conferences for a number of years because my wife is a transplant recipient, and we've just learned a lot from these conferences. And I also, in another part of my life, I also do volunteer work in a prison, and it's the prison ministries. And I originally didn't put the two together and as related. However, just very recently, one of the prisoners that's in the group has said, well, you know, my kidneys are not in good shape, and I think they're going to have to put me on dialysis. And I said, oh, okay. And, you know, I guess one thing about that is it's a different situation because, well, first of all, he has to go to a different prison because we have a lot of prisons in Missouri, and one of them, they have a dialysis availability. And I don't know if this is just something that you got to think of, because we've been talking about free people, and it's a very different system in that they don't have choice. You know, they don't let them just go, well, I think I'll go to this doctor, you know. But anyway, I just wonder if there's been thoughts about, because I know it's got to be a growing population because they put people a lot in prisons and they get old and they get diseases, and this is the first time this has actually come up. I didn't put the two together. I wonder if there have been thoughts or people working on that kind of
Thanks for raising it. Two things. Number one, consider yourself a potential recruit. Number two, this issue that is being referenced. So incarcerated populations in states, in state prison systems, even if they're under contract, choice is much less, and it's usually a designated facility for geriatric or special need population for incarceration. I was familiar with that, having been Deputy Secretary of Health in Virginia. And in terms of patient choice, there isn't a lot. However, the basic human desire about information about your disease, how to feel more empowered and not feel like you're subject to the disease is critically important. And that's why I actually think it's a great idea to be able to reach out to folks, because people need their information and how to manage disease. And I think it's important. Well, I think we'll probably end up talking to you about that. Because look, it impacts everybody. We're not making distinctions. The most important thing is knowing about the care that you get and potential choices that you might have. And sometimes you're educating administrative staff who may not know. And that's especially true in state hospitals, having gone through a whole period in Virginia of deinstitutionalization in mental institutions and the closing of state facilities where patients, in my opinion, did not have adequate representation, access, nor a certain level of empathy and care. And I had a great opportunity to be on a team that helped change a lot of that. And I think the same thing. When you can identify a pocket population that needs outreach, I think that's a good thing. So we'll definitely talk to you about that. Hey, Nicole.
Hi, I'm Nicole Jefferson.
Just so everybody knows, Nicole Jefferson, she is a rock star. She is kidney precision medicine. She is a spokesperson. She's an ambassador. And go ahead.
So as an ambassador, I have a question, and I guess maybe this would be Aaron's topic. I know you brought up certification, which I'm very excited about to hear. But I was wondering, will there be levels to the certification? So if I choose that I want to do just education and awareness, I don't necessarily have to do the policy for HEALS and things of that nature?
And excuse me, that's a wonderful question. We will have different levels. There are different modules, and they will kind of focus on a certain area. So if you have an interest in pediatrics, you have an interest in veterans, we will have a training module more specific to that focus. And you can decide if you want to go the full way through the certification program or if you just want to touch on certain topics that are of most interest to you.
And, you know, to kind of piggyback on that, as we're laying it out, we're kind of trying to formulate, you know, how we want to go about this and what would be received really well. So we'll probably, once drafts are developed, we'll probably reach out to some of our ambassadors and get some initial feedback. But I think one of the concepts we've been kind of throwing around too is, you know, creating a number of modules, and then to receive the certification is selecting a certain number of those total modules. So that way you can participate in those that are most interesting and relevant to you.
And would I be able to have like a certain certification that I'm certified in education? So if I needed to do AAKP education or awareness, and then if I chose to do have the certification for, you know, the policies and things like that, I would have a different certification.
As the certification is completed, you know, we are envisioning like a certificate as well as, you know, the credential, and so it would outline the particular avenue that you went into.
And so everybody is probably familiar with this executive education. I think universities and colleges realized a long time ago, if you want to be relevant in lifelong learning, you need to be able to provide information over time that's not a 4-year commitment. But it's a very similar type of program that we'll be offering online. And so you get a basic core of knowledge, and then you can add on to that and have a specialization. And then the broader deep dive, if somebody has the time to do all of them, you'll be able to do that also. But again, this is something that we've been talking about internally for a couple of years. We have a lot of folks that are experts on executive education that are helping us on it, and 2020 is a good year for that. Go right ahead.
So just while we're on the subject of education and getting more doctors or medical doctors interested into nephrology, I just kind of want to make the point that not only is there a disconnect between patients and their medical doctors, but there's a disconnect between actual kidney disease in real life and the researchers actually working on the therapies and drug discovery and mechanisms of all this. So I work in one such lab where even my PI, he's a professor in the nephrology department, he's a PhD, not MD, or MD, PhD, even he says stupid things about kidney disease sometimes. So there is that disconnect, and I just want to make the point that I think it would be a good idea to try and draw outside engineers, scientists into nephrology. It's hard enough to get doctors in there, but we want more of everybody involved.
That's a great point. And in regard to stupid, I might think that only you can say it. And for those who are a little bit challenged, we'll make certain opportunities are available for everybody. Is that well said, Dr. Smith? Okay, thanks. Next question.
Hi, I'm Ed Ogier. We live in Glendale, Arizona. I was kind of forced to be a life member of this organization many years ago. Let me explain. In the 1970s and 80s, myself and my sister was developing kidney disease, and my mother, in a panic, you might say, wanting information, and so she lived in Laguna Beach, so she started visiting Dr. Gentile, and he provided her with information and little therapy along the way. They became friends. And so he mentioned this organization because he was involved in some manner of it. So she sent $1,000 in for me to be a life member around 1984. So throughout the years, I'm getting to the point what I'm saying here, I read about your Hill Days. I see pictures of many people talking about the Hill Days. Well, how do you do that? And I'm a phlegmatic. How do you do that stuff, you know? So this weekend, we had prearranged a Capitol tour with our Congress lady. Matter of fact, my wife met her at the nail salon where she goes to. And we gave a great private tour. And I'm talking about the organization, talking about our lives. We get back to the office, And the guy that gave us the tour says, oh, you need to meet Annie. She handles our health information stuff. Here's a card. Let's keep in touch. How easy is that? How easy was that? So that's what you need to do.
All of us would agree. Number one, there's an old adage, all politics is local, including nail salons. And as Richard always says, where you get your hair cut. But it's a great example of it is that easy. And imagine if things are that easy and then you have knowledge to impart. And there's a demand for it. And it is continued relevance for the patients. And thank you for being a life member. We know you will. But with that, if there are no other questions, I'll ask Richard to go ahead and close us out so folks can get on the road. And again, to everybody, thank you very much. And a special thank you. You see these guys operating up the cameras. You see over here in the skirted pit. This is Briar Patch Media. They're good friends of AAKP. They do great professional work. This is professionally filmed and live streamed. And again, our commitment is to make certain that these education components here, all of these presentations, are available to people, but they're only available if the quality is good and the sound is good and the editing is superb. So all the ifs, ands, ums, and bad things that happen, Jonathan St. John is a saint to anybody who's on TV. He makes you look really great afterwards. So to Briar Patch Media, we offer a round of applause. Thank you. Sorry, one last question. Go right ahead.
Before you close, Richard, excuse me. Well, first of all, my name is Damien Asha. I'm from Atlanta, Georgia, and I first need to just thank everybody for this opportunity to be here. I have to say it's been quite overwhelming. I'm fairly new to this and a new ambassador. But with that said, in my community, I'm seeing a lot of dialysis just being built on every corner. So it's getting to the point where it's really kind of frustrating at this point. And so my question is, I know we have a lot of project initiative with AAKP, but if it's by chance, if I identify some gaps in my community and I want to begin or create or develop a project initiative, which I'm just started doing, is it possible that I can reach out to the organization for influential power or some leverage? I have reached out to a lot of the dialysis companies. I haven't gotten any return calls or return emails. And I did a couple of other things in the community, and no one is really responding. And so with that said, I want to make sure I'm very respectful to the organization and as an ambassador, and I don't want to create any conflict because I am representing AAKP, but at the same time, I think is at the point where I have identified that I need some power or influential power or leverage. And so I just want to just kind of ask you guys, is that an option for me?
Quick comment. You've put your finger on an important issue. So yes, AAKP, when folks come to us and they have a great idea, they want to be involved in their community, I'll give you an example. Patrick G., who's one of our ambassadors, he's on our board, very energetic guy, he's a pastor. He's in Richmond, Virginia, some of the toughest neighborhoods. His request was simple: arm me with the brochures and information I need to go out and be a peer educator to folks on nutrition and to help people get organized to ask the right questions of their doctors and their dialysis providers. So we are happy to do that. Aaron can plug you in and get you all set up for whatever you need. If it's a social, if it's a community event, if it's just walking around. Approaching dialysis centers, there's a particular, obviously because of health information privacy and other issues, there are sensitivities that are involved. Not so much that I've encountered if you have a good conversation with nonprofit providers, but every different facility has its own protocol. Having said that, I'll give my own editorial comment about this. Dialysis in the United States is provided by the U.S. taxpayer under the auspices of the federal government. And so large dialysis industries benefit from a system that has been set up like that. And as people who are free market, who celebrate the fact that people have dialysis and live, that's an important thing. However, in my opinion, I actually think that modern dialysis, large corporations have done themselves a disservice by becoming disconnected from the voices and the grassroots of those who they assert that they service. And you're pointing out a very important issue because the presumption is that patient information can only come from a company or a designated official in a facility. We actually think it's the other way around. So we go around a lot of that hubris by contacting patients online and letting them have the information they need to be effective. It's a difficult issue, and this whole idea that dialysis facilities are popping up on every corner, we see it, we travel a lot. We're all over the United States, a very competitive business, and it is a business, it's a large corporate business. We're a free market, we understand that, but the goal of everything that you've heard here is, let's change the model. There's a magnificent book called The Magnificent Ambersons, and it's a story of a family that's very prominent, and their entire wealth is created through horse and buggy and that type of stuff. And there's this young upstart that wants to come into the family and marry into the family, and he's got this funny thing called a motorized cart. Well, make a long story short, many years later, it's that person that was involved in the automobile that saves the family that was in horse and buggy. And that's exactly the same analogy for a lot of the folks that are seeing these dialysis centers set up. More preemptive transplant, more home care, more choice is what is ultimately going to drive a change and pop up on every corner, because it's going to be consumer demand and people understanding that you can pursue your aspirations, pursue your life, and not be dependent upon one type of formulaic care and therapy. Barry Smith, the Rogerson Institute, is a great example of that. We will educate everybody, including large dialysis providers, but the question that you're asking about engaging your community is a great one, because that's where it has to happen. And unfortunately, if you look at the statistics that Dr. Lee has put up here and others over the years, that level of engagement in local communities is hard to reach in disparate communities. In my opinion, it's abysmal. So thanks for the courage of standing up and asking. We'll be happy to arm you with what you need. Okay, Richard? Oh, great.
Hi, Damien. Thank you so much for being here. I know we've talked before, and you did a fantastic job just raising awareness about this event, and we're thrilled that you've been able to join us. You may have heard about our recent PCORI Award, the Engagement Award that Dr. Lee has been talking about, and that will be taking place in Georgia, the Peer Mentorship Program, and that's doing a lot of what you're talking about, educating, providing support for somebody who may be newly diagnosed and not sure what the process is and where to go and what their options are. So we would love to pull you into that, and the hope is that this will be a stepping stone for us to go into other communities. So we're starting in Georgia, but we hope to expand that.
Great. Well, I want to thank the panel. They did a great job. Give them a hand, please. You know, part of what we're here for is to, hey, I found my glasses. I couldn't find these. You guys been hiding them out, hiding from me. You know, from the dollar store, though, so it wasn't great expense. But anyway, that's what it's about. You guys asked some great questions and gave us some great ideas. There's a lot of answers in this room, and we need your input. So several of the questions and responses that you gave us are very helpful. The other thing I want to say is thank you for your patience and staying with us. We know it's been a long weekend, a lot of information. Many of you have to travel, so we really appreciate you staying with us this morning so we can do this. And while you're here, I want to take one more chance to thank those who allowed us to do what we're doing, our sponsors. Want to thank Amgen, Horizon, Mallinckrodt, CareDx, Next Stage, Akebia, Baxter, Bayer, DCI, Hansa Biopharma, Reata, Retrofin, Advocin, Nessus. You guys get some of those drinks that were out there. Opto Reno, Somatus, and Vitafuel. It's very important that we acknowledge and recognize and appreciate them, because it is their generosity that allows us to do what we do. The weekend, there are many people who came here on scholarships. There are many people, obviously, we had the box lunches and the other things, so we're able to do this type of event thanks to them. And in closing, we'll just keep it very short. Again, we want to thank you for being here, leave you with a charge. If many of you attended the sessions, many of the sessions that were going on, I was saddened because I couldn't attend them all. There was just so much information that was given out. We need feedback from you. Drop us a line. Let us know what you liked, what you didn't like. If you have some suggestions as to what we can do next year, it's not us. It's not us up here. It's us in this room. We're all part of the, think tank and the group that's going to make decisions about what we do. So if you've got a good idea, we certainly want to hear it. I think that we have a number of organizations that we've talked about working with. We're going to continue to work with them. We're going to work with them at a higher level. We're not always going to agree on everything, but that's okay. I think most of us agree on a large percent of the things that need to be done, and ultimately we know that everybody in this kidney space is motivated and interested in doing what's best for the patient. And as patients, we simply want to have some input about things that are going to happen and impact us. So I think it's very important that, and we always are respectful to the professionals, and at the same time we want our voice to be heard and have the input about things that are going to ultimately have an impact on our lives. And as I talk with many of you and listen to your stories and what you've been through, it really just keeps me humble and make me thankful for what the docs were able to do for me in terms of allowing me to have this quality of life. And many of you have been through the same thing. It's not perfect, but it's a lot better than what it has been or what it might have been without the innovations, the medications, and the other progressive changes that have been made over the last few years. And we think that the future is very bright in terms of what is going to happen. And as Paul said, and everybody else up here said, we're going to look at the big idea, and we're going to take a shot at really making that happen from a global perspective. United States is great, but there are things that are going on in other parts of the world that we can certainly benefit from. We've had many patients come here and give us their insights about how things are where they're from. We're appreciative of that. We want to continue to listen to anyone that has a good idea. So again, I want to thank everyone for coming out. We really, we're humbled that you guys made the trips from the distances that you've come from, participated in the venue that we had today, and we're all going to wish you a safe journey home and look forward to the next event that we have. So thank you very much, everybody, and have a safe journey home.